Medurstand Understanding Medicine.
I am Professor Azizur Rahman, and after introduction to congenital heart diseases in adults, we're going to take up now left to right shunt. Now, I explained in the last video that any shunt in the heart, it may be at atrial level or ventricle level or great vessel level, it will be from left to right because pressure in the left side is usually higher than the pressure on the right side. Now, this is the cartoon. Now, this is a schematic diagram. This is the left side. You could imagine the blood coming from the venous side. This would represent pulmonary vein, left atrium, left ventricle, and aorta. So this is the left side. This is coded in red because this carries oxygenated blood. And this is a high pressure system. And this one is like inferior vena cava, superior vena cava, right atrium, right ventricle, and pulmonary vein. Of course, this is a schematic diagram. It's not anatomically accurate. But this highlights that there are two separate circulations, and when we talk in terms of physiology, they are in the series. Whatever blood passes through this system, then through capillaries will go to this system and then will pass through the right-sided system also. But anatomically, they are parallel to each other. Now, we have already discussed, I think more than once, that pressure at all level is higher on the left side. Now, take the example of atrium. Pressure in the left atrium would be higher than the pressure in the right atrium. Pressure in the left ventricle is higher than the pressure in the right ventricle. Pressure in the aorta is higher than pressure in the pulmonary artery. So if there is an abnormal communication, blood will always flow following the simple physics formula, physics principle, the principle of gradient. It will always flow from higher pressure to the lower pressure. So if there is an atrial septal defect, it would result a blood flow from the left to right, and this blood will then recirculate through the lungs. If there is ventricular septal defect, blood will be shunted from the left ventricle to the right ventricle, and then onward from right ventricle it will recirculate through the pulmonary circulation. Similarly, if there is patent ductus arteriosus, blood from the aorta will be shunted to the pulmonary artery and then it will pass through the lungs. In either case, blood from the left side is shunted to the right side and it gets circulated through the lungs again. Now, I think if you want to really understand the common features of these three shunts, you need to understand this picture. So I have drawn this two circulation, left-sided circulation in red, this is systemic circulation, and right-sided circulation is in the blue, which is pulmonary circulation. And there are three possible sites of defect. This is the intra-atrial septum, this is intraventricular septum, and this is between aorta and pulmonary artery. Now let's see first the normal circulation. I hope I am able to depict it correctly. So this diagram shows that whatever blood passes through the systemic circulation also has to pass through the pulmonary circulation. So although the systemic bed is much bigger than the pulmonary bed, but actually the volume of blood which passes through the systemic circulation is exactly the same as that the one which passes through the pulmonary circulation, right? Minus few millimeters which comes from the bronchial vessels. So I think that you can ignore the blood, the left-sided systemic circulation equals right-sided pulmonary circulation, and there is no shunting. Now, if there is a defect here in the intra-atrial septum, then some blood is coming all the way and going to the systemic circulation, but some blood will be actually reverted back from the left atrium. Instead of going to the left ventricle, it would go to the right atrium. Why it would do so? Because there is a shunt. Now, why it would go from the left to right? Because the pressure in the left side is higher than the pressure in the pressure in the left side is more than the pressure in the right side. So there will be shunting of blood from the left atrium to the right atrium, and from right atrium it will go to the right ventricle, pulmonary artery and lungs. So pulmonary circulation here is more than systemic circulation. How more? This would depend upon the size of the shunt. It could be 2 times, it could be 3 times, it could be 4 times. So depending upon the size of the shunt, the pulmonary circulation will be more than the systemic circulation. Now, if you take the example of VSD, ventricular septal defect, so the level of shunting is different because this time it is from the left ventricle to the right ventricle, but everything else is the same. Blood is passing through the pulmonary circulation is more than that passing through the systemic circulation. And the blood which is shunting from the left to the right is oxygenated. Please appreciate this point. Blood in the left ventricle or left atrium is already oxygenated, and it will go through the lungs, will get reoxygenated. It cannot get more oxygenated because it is already 100% oxygenated. But the important point is that the blood whichever goes to the systemic circulation is fully oxygenated. So there would be no cyanosis in either of these conditions. Where there is left to right shunt, there will be no cyanosis, and there will be pulmonary circulation will be 2, 3, 4 times more than systemic circulation. Exactly same will happen if there is patent ductus arteriosus, except that the level is different. So I think I may not repeat the same statement again. So the same would apply here. So common features of left to right shunt, if you understand them well, whatever the short case or long case may be, the same would apply to all. Number one, there is no cyanosis because in either of the three conditions, oxygenated blood from the left side gets shunted to the right side, passes through the lungs again. It is only an extra load on the heart, but the blood which is present in the left ventricle, which goes on to the aorta and the rest of the body, will be fully oxygenated, and there will be no cyanosis. No central cyanosis, no peripheral cyanosis. All right, so this is important. Then there will be no clubbing also. Clubbing is commonly associated with some congenital heart diseases, and it is a very, very important finding. So it is actually the chronic hypoxic state which causes clubbing, and especially if this chronic hypoxic state develops when the child is growing in size. Since there is no cyanosis in left to right shunt, so there will be no clubbing. If there is clubbing, you might suspect right to left shunt, not left to right shunt. Or there may be an occasional case who had actually left to right shunt, but later on it got reversed, and which we will discuss shortly. How can that happen? Then, since these patients are acyanotic, that means they do not have cyanosis, and cyanosis is something which mothers can recognize, and the children with right to left shunt, they tend to present early. They tend to be more symptomatic, and they tend to present early, and the diagnosis is usually made early. But patients, the children with left to right shunt, since they do not have this cardinal symptom of cyanosis, they may get unnoticed. They may be having some repeated chest infections or some chest congestion. They're treated with simple medication, but unfortunately, a diagnosis of left to right shunt may be missed because these children have minimal symptoms, especially they do not have cyanosis. So that is why the diagnosis is typically delayed. Then in all three conditions, atrial septal defect, ventricular septal defect, or patent ductus arteriosus, all three conditions, pulmonary circulation is increased, because at some level left-sided blood is shunted to the right, and the right-sided blood circulation passing through the lungs is more than the left side, because in this case the blood which is coming from the peripheries, from the legs and the arms and the brain, that is also passing through the lungs, but the blood which was actually supposed to go to the aorta from left atrium and then left ventricle then to aorta, part of it is shunted to the right, so pulmonary circulation is increased. Since there is a mechanism of auto-regulation, if there is increased pulmonary circulation, there will be some vasoconstriction and there will be increased pulmonary pressure also. You know, normally pulmonary pressure is less than the aortic pressure. In this case, pulmonary pressure will be higher than normal, but not necessarily higher than the aorta, but gradually as the time passes, pulmonary pressure will progressively increase. And a time might come when pulmonary pressure actually exceeds aortic pressure, and that is the time when there is a reversal. And that next picture will show it in more detail. And there is a possibility of reversal of shunt, and especially if these patients are ignored. Uh, right to left shunt never gets reversed. It is only the left to right shunt which may get reversed later in life, because as I just mentioned, pulmonary pressure will progressively increase, and there will be a time when the shunt may be both ways. Sometimes blood is going from the left to the right, and sometimes it is going from the right to the left. And then when the pulmonary pressure increases further, then there will be complete right to left shunt, and at this stage patient becomes inoperable. Now this is actually the same thing shown in a slightly different manner. I think maybe it explains the concept better. So there is primarily left to right shunt, either ASD or VSD or PDA. All three behave the same way. There is increased pulmonary circulation 2 times, 3 times, 4 times. We have already discussed. Now then there is a mechanism of auto-regulation. That means all our tissues, they actually regulate their own blood supply. Now in this case, lungs are getting 3 to 4 times more blood than they should normally get. So there will be vasoconstriction. Initially this is purely spasm of arterioles, but later on there is hypertrophy of the arterial wall. Later on there may be fibrosis. So pulmonary pressure not only progresses with time, it becomes more and more irreversible. Then there is pulmonary hypertension. That means pulmonary pressure increases progressively, and then when pulmonary pressure exceeds that of aortic pressure, then there is the reversal of shunt. Now what is the importance? Of course, as time passes, the child is likely to become more and more symptomatic. The sinuses will start appearing here. Once sinuses start appearing, clubbing may also start appearing, and there will be more and more dyspnea. And I think if the child is lucky to be diagnosed early, before pulmonary hypertension develop and the shunt is repaired, the child would have a reasonably good life, if not normal life. Now, I think for students, it may be of interest that these days it is possible to have the diagnosis of a congenital heart disease before birth, and it is possible to operate in utero, and when the child is born, the child is actually without a defect. This has got great benefits because the in utero repair will allow the normal growth of the heart and the baby. So imagine in developed worlds, they are operating before the birth, fetus is operated in utero. And in poor societies, in poor countries like ours, the diagnosis is missed till something happens and pulmonary hypertension develops and reversal of shunt occurs, and at this level repair is not possible. Now, technically, repair may be possible, but repair can actually worsen the situation. How? Because if there is a reversal of shunt, circulation is still going on. If somebody closes this shunt, then blood will be forced to pass through the lungs, and there is so much pulmonary hypertension, blood will not be able to pass through the stenotic vessel, and there will be acute cor pulmonale, there will be acute right heart failure. So the patient was alive with cyanosis, but after operation, because of this acute cor pulmonale, there may be actually death. So typically, once pulmonary hypertension develops, operation is contraindicated. This is actually a very expert opinion. Where to draw the line, this only I think the cardiac surgeon and cardiologist will determine. But you need to know that if valuable time is wasted, then operation will become impossible. And please remember, when there is a need for operation, the person may be actually asymptomatic. So I think it would be then the role of echo and Doppler, which can see that the pulmonary hypertension is developing. You might not operate on those who are absolutely asymptomatic and pulmonary pressure is normal. But those who are becoming symptomatic, their physical capacity is reducing, and there is evidence of pulmonary hypertension, they should be operated as early as possible. And I will discuss in those lectures, the separate lectures on ASD and VSD. You will appreciate that these things can be repaired without even opening the chest. So I think we should never let this opportunity go. As a physician, as a pediatrician, and as postgraduate students, it is our duty to recognize these conditions early and to refer them to a person who can actually operate on them. So this was it. Actually, we today talked about just the common features which are applicable to all three left to right shunts, ASD, VSD, and PDA. If you have understood that, whatever the case may be, you can apply the same principles. All these three conditions are characterized by no cyanosis, no clubbing, late diagnosis, pulmonary hypertension, and reversal of shunt. With that, I'd like to thank you. This is Professor Azizur Rahman from Medurstand, and I'm really looking forward that you join me in the next presentation, next video, which will be on, I think, atrial septal defect. Thank you.